Everyone, and welcome to today's webinar focused on fast AST or antimicrobial susceptibility testing. Thank you all for joining. My name is Brian Maynard. I'm a medical science liaison here at bioMeriU. I'll be moderating our discussion today. So we have a great agenda ahead of us. For the first portion of the session, our speaker, Dr. Nathan Everson from Henry Ford Hospital, will share his experience implementing fast AST at his institution. Then I'll come back and lead a Q&A session with Dr. Everson, where we'll dig a little bit deeper into what drives successful implementation and what's been most impactful in practice. So before we get started, just a few housekeeping items. If you can advance the slide. Of course, we want this to be interactive, so please submit any questions as they come up using the Q&A feature, and we'll try to get to as many as we can. That's going to be the question mark in the upper right-hand corner. You can see there's also a chat icon. Please use that if you're experiencing any sort of technical difficulties. You could send a message directly to us as the organizers, and we'll help get that resolved. And then finally, I apologize, but due to technical difficulties, subtitles are currently available only in English at this time, and you can find the caption button at the bottom right. All right, so if you advance the slide, I can introduce our speaker today. So Dr. Nathan Everson is a clinical pharmacy specialist in infectious diseases at Henry Ford Hospital in Detroit, Michigan. He brings more than 15 years of clinical experience across diverse practice settings, including over a decade serving as a residency program director. His professional interests focus on leveraging the electronic medical record to advance antimicrobial stewardship, promoting sexual health, and strengthening residency education. So with that, I'll hand it over to Dr. Everson.
Awesome. I appreciate the introduction. We'll launch right in, start talking about fast AST in practice. Can advance to the next slide. So only disclosure I have, I did receive honoraria from bioMeriU. Other than that, I don't have any other disclosures relevant to the presentation. Next. So objectives, we're going to briefly talk about the VITEK REVEAL. I imagine some of you have some baseline knowledge, but we're going to kind of hit the high points about what the technology is. And then we'll spend the bulk of the time talking about clinical implementation approaches. And lastly, we're going to apply some of the concepts to some actual patient cases that we've seen with the REVEAL post-implementation. So here we got a timeline of treatment decision making, and I think we've used terms like targeted therapy and empiric therapy a lot in the past as kind of two discrete things, and I really view them as more of a spectrum. So you're going to start with your empiric therapy, and as you get more information, you get more targeted. You know, some patients go through 2 or 3 drug changes throughout a course of treatment as we get more information and know more about what's happening. If you want to pop the next slide for me. The first kind of window I want to talk about is that window prior to culture positivity and what sort of technology we have there. So we've got biomarkers, things like procalcitonin, CRP. They may help us kind of determine whether someone has a bacterial infection or not before we have cultures kind of confirming anything. We've got specific organism antigen antibody assays. We've got things like Legionella urine antigen or fungal PCRs from blood. We also have a newer technology with pan-organism sequencing, so like the Carius test from blood. And then we, of course, have our blood culture cabinets, which the technology has advanced quite a bit there in improving that time to positivity and improving the yield of our blood cultures. So the next window here is going to be between having a culture that's turned positive and then identifying the organism. So allowing us to make a decision to change antibiotics, either to escalate or de-escalate, depending on what the organism is. So we have our classic benchtop biochemical tests that we're all familiar with and still all of our microlabs use to some degree. Our automated identification cabinets, which have been in practice for a long time. So examples like VITEK, Microscan, and BD Phoenix. And then newer technology that a lot of us have implemented would be our rapid PCR identification, as well as resistance genes. So examples here would be, of course, the BioFire BCID2 and the Verigene, which I've experience with both of those systems. And then we have our multi-TOF identification that's is also used pretty frequently. So as we move into the next section here, I feel like this is the area where we have kind of maybe the least that's come out in terms of shortening the window. So we have our classic benchtop susceptibility testing. We've got broth microdilution, E-test, sensititer, Kirby-Bauer, and we've done a lot of work in improving the quality of these susceptibilities and getting better information. But the time frame still relies on us to culture the or get the organism from the culture, get a pure organism on a plate, and then use these systems. So our automated susceptibility cabinets, which I think most folks use, examples, of course, we are the same as identification cabinets. They still, we have to have that 18 to 24 hours of growth on a pure plate before we can use them. And so this is where we're going to spend the bulk of our conversation talking about is the phenotypic AST directly from the positive culture, where we can kind of bypass that day of waiting. So examples would be the Accelerate Pheno, and then of course what we're talking about today would be the VITEK Reveal. And so the Reveal gives you rapid susceptibility directly from a positive blood culture. The GNO2 card is the one that's approved here in the United States. There's also a GNO1 card that is available in Europe. It does have a little bit different combination of drugs and bugs, but in the US we have 12 gram-negative bacteria and 16 antibiotics on the card. Removes that need for that 18-hour plate incubation that we discussed, and then your results are going to be after going on the machine anywhere from 3 to 6 hours. Kind of the average is going to be between that 5 and 6 hour range. The technology itself is really interesting. So it's the cards have a small molecule sensor on them that are detecting volatile compounds that are kind of produced by the organism as it's starting to grow. So as opposed to looking for actual growth and measuring that, it's looking at the presence of these as kind of a surrogate for growth. So there's wells of varying antibiotic concentrations in the card, which then kind of provides almost like a broth microdilution-like approach to determining the MICs. So here's the example of the card here. So you can see where the wells, all those little circles are the various wells of antibiotic concentration. And then it's going to go and kind of be placed on the machine. And then in that up to 6 hour range, you're going to have them change color if they're detecting these various volatile compounds. So kind of an example here with the blue line would be the 2 micrograms per ml concentration of meropenem, and then the green line here at the bottom would be the 4 microgram concentration. And so you can see we had the detection of those compounds at the 2, but not or minimal detection of the compounds at 4, giving us the inhibition or the MIC. Next slide, please. So here's the available organisms that we have on the GNO2. As you can see from the organism list, the gram-negatives we have here are a pretty expansive list. A lot of the big players in clinical infections that we see. And then antibiotic-wise, a pretty broad list of antibiotics as well. I was really excited to see things like meropenem vaporbactam and ceftazine avibactam, because we have those agents as, usually add-on testing when we think there's resistance. And this way we get some of those up front and kind of reduce that delay even further to finding out whether some of those agents are susceptible and drug resistance. Next slide, please. So the big bulk of the time, we're going to talk about implementation. So we've had the Reveal kind of working for several months now, and so we're going to kind of talk through different kind of decision points you might have if you're considering implementing the Reveal. So we can pop to the next slide. A little bit about my practice site, so you can kind of know where I'm coming from, because we're all going to have different resources. I'm at Henry Ford Health. It's a 13 hospital system in Southeast Michigan. We have over 250 outpatient locations. In terms of our microbiology, we've got centralized microbiology services that covers 5 of our inpatient hospitals, including our largest hospital in downtown Detroit, where I'm at right now. We have 24/7 operations, clinical microbiologists on site, and then we have kind of the main microtechnology that does the bulk of our work. We use the VITEK 2 for susceptibility testing cards. We have the MALDI-TOF for identification, and we also use the BioFire BCID2 for rapid PCRs from blood. In terms of our antimicrobial stewardship setting, we have a pretty robust system-wide stewardship group. We have dedicated ID pharmacists at all of our sites, and they are responsible, at least during the day shift, for rapid diagnostic follow-up as well as audit feedback. And we'll talk quite a bit more about that, kind of that setup and how to follow up with results a little bit later. So we're going to start with the first kind of question that we have, and I think this is one of the use the Reveal for. So we got our list of organisms again here on the right-hand side. So I think I would start looking at your resistance urine is a good place to start in terms of what you're really struggling with. What are your more resistant organisms? What are you seeing in terms of that? And that may help you kind of determine where the reveal might make the most sense. Looking at your existing technology as well. So how would the reveal marry with whatever you're doing currently? So rapid PCR from whole blood, resistance markers, things like CDXM on E. coli is going to capture the vast majority of ESBLs, and so that's often a big determinant of what we're going to cover. So does this add much on top of that? And I think that results may vary, or the mileage may vary depending on what your site's like and what your organisms are like. One of our cases will kind of cover maybe the benefit of this on top of running these PCRs. And then we also need to think about the organisms on this list that maybe the genetic identification isn't that helpful when it comes to resistance. So looking at you, Pseudomonas, where a lot of our resistance for Pseudomonas is not due to detectable beta-lactamases that we get on something like the VAER gene or the BCID. So we're not getting porin changes, we're not getting efflux pumps, we're not getting AMC hyperproduction. And so getting early susceptibilities in an organism like Pseudomonas may have a lot more bang for your buck when it comes to escalation. I can pop to the next slide. So our approach and how we kind of tackled this was we initially rolled this out for E. coli and Cleb pneumo. It's just kind of odd to say when I just talked about how excited I was about Pseudomonas, but we do have BCID running concurrently with this, which does give us resistance genes. But our focus here for E. coli and Cleb pneumo was our opportunities for early de-escalation. So when we get these results back, can we get someone on an oral agent sooner rather than later? We're very big on oral agent advocacy at Henry Ford. It's a really big kind of cornerstone of our stewardship program, is advocating for oral use and using oral wherever there's data to kind of support it. And we thought this would be an excellent opportunity for us to kind of push that metric a little bit more. We do plan to roll out for other organisms. We do have kind of a local issue with our lab software, where when we run additional susceptibilities with automated susceptibility cards, we're getting duplicates. And so we've kind of held off until we can kind of get that patched, which apparently is coming very soon. And then we plan to kind of expand it more. And I'm definitely excited for Pseudomonas and Acinetobacter as additions in the future. The next slide here is going to talk about our drug susceptibilities. So on the right side of the screen, you're seeing the FDA-approved combinations of organisms and drugs. So you can see there are definitely like holes in here where not every drug is covered on the reveal. So you might want to look at this and figure out what of these organisms are you going to run additional susceptibilities on. And often you may want to do a automated susceptibility card in addition, and then kind of fill in those gaps with the additional susceptibilities, which will create kind of a bimodal like report structure of having some of your susceptibilities and then additional ones coming later. We didn't really feel like this is that big of a concern because we're already kind of seeing that right now when we have things with our automated susceptibility where we have to do benchtop e-tests to confirm if it's certain MICs. Cefepime is a frequent one where we have to do confirmatory testing. And so our providers are also used to some of that dragging behind. But you'd want to think in how you want to communicate in your results that there might be some additional susceptibilities coming, or like a wave 2 essentially. There are additional susceptibilities that can be done in the reveal, but that will require local validation for that. And we'll talk about that in a second. And then each drug is reported individually on the reveal platform. And so you'll get certain drugs that come back before others. So you do have the option potentially of reporting drugs as they come back. I think this does present potentially a lot of issues when it comes to microtech time and energy, and then kind of is the juice versus the squeeze kind of thing. In general, you're looking at anywhere from 3 to 7 hours. And so if you wait that 7 hours for all the susceptibilities, it's only a few hour difference, and you're already kind of shaving off a day for these. So you can kind of approach that how you would. Next slide, we'll kind of compare our susceptibilities. So we've got the FDA breakpoint configuration that I had on the previous slide next to the CLSI breakpoint configuration. So we've got 108 combinations versus 144 combinations. And so kind of the FDA breakpoint is kind of your out of the box with the reveal when it gets started. And then the CLSI gives you options to do local validation on and to kind of add these additional susceptibilities into your reveal, which is a great option, but that does require time and energy and manpower from your micro lab. And so kind of taking that into account when you're deciding how far you want to go with this. And if you can see with E. coli and Clebpneumo, kind of looking down the list there for the FDA breakpoint configuration, you'll see kind of why we selected those two agents. So while we have this issue with our duplicates on our susceptibility card, those ones we felt we didn't need to run an additional susceptibility card on because they're really complete in terms of all the major drugs that we would use. So that's why we rolled out with those two. Move on to the next slide. So here is this bar graph at the bottom is showing kind of the range where these different drugs will come back on the reveal platform. So it could be as short as 3 hours in some of them, where the average is still kind of between 5 and 6 hours. And then you're seeing the reveal kind of results on the platform on the right-hand side, where you're seeing the results kind of coming back as it's being done. So this is hypothetically where microtech kind of watch and see as results come back and report them in the EMAR. But again, the juice might not be worth the squeeze for that. Next slide. So our approach here was we didn't want to do additional susceptibility cards up front due to our kind of limitations. So that's why we chose E. coli and Cleb. We do plan to expand it to other CLSI combinations in the long term, and so do that local validation. We're kind of identifying which bug drug combinations we care the most about and prioritizing that for the microlab because it will be a lot of work. We're also integrating with like a bunch of other hospitals right now, so our microlab has a lot on their plate. So trying to make sure we're identifying things that are really useful. We opted to release our susceptibilities when they were complete on the reveal and not reporting them as they came back because it just seemed like a lot of work on our microtext for only a couple hour difference that we didn't kind of question the clinical utility of that. We can move on to the next topic. So your patient population and who you want to run the VITEK reveal on. So should you run it on everybody who has a gram-negative bacterium with one of the organisms that it's approved for? Or are you going to focus it in on patient populations that you think it will do the most good? So some areas that we talked about when we were doing our initial conversations would be like location determination. So are you only going to run it on ICU patients who are likely to be more sick and tend to have more severe infections? Are you going to run it in your ED where you can get someone on therapy quicker, potentially reducing length of stay, maybe even discharges from the ED? Are you going to risk stratify your patients and focus on if you have a really large immunocompromised patient population, will you focus on those patients who earlier susceptibilities might be beneficial, seeing as you have limited immune system to kind of assist, or are you going to focus on severe sepsis? And so there are areas you could drill down on if you wanted to roll out the reveal for specific populations. I think an important follow-up question to that, though, is what ability does your microbiology staff have to determine whether these patients meet criteria for reveal or not? Most micro labs are not doing a chart review as they're doing their workup. They don't have remote enough time for that. So you could potentially implement a reveal test. So it would be ordered by the provider that this would be a rapid AST. But then you have to educate your providers that they understand how that works. I'd say outside of infectious disease physicians, it's pretty rare for a provider to have a really strong knowledge of what's happening in the microlab. And so that kind of brings a whole host of education issues if you're going to go that route that you should take into consideration before doing it. So move forward to the next slide. Talk a little bit about our approach. We elected to not limit the AST testing. So we are going to do it on all E. coli bacteremias as well as Clebpneumo. We kind of felt from a clinical standpoint, we are a really high acuity center, and we felt that running it on all patients was beneficial, particularly when we're looking at opportunities for early de-escalation, increased throughput, getting people out of the hospital quicker, which we know tends to be the best for patients. And then automatically run the test on relevant organisms. We did not implement a separate order. We thought the education component of teaching providers the appropriate way to use the reveal would be the lift would be a little too heavy for us. And this way it's just kind of factored into our micro process for those organisms. The next slide here is services. of literature and rapid diagnostics that if you don't have a point person or you have someone who's following up on a rapid diagnostic culture or rapid diagnostic, particularly something that's new and not in a workflow already, you have really limited returns on that technology. And obviously, if we're going to spend money on new technology, we want it to work and not have no impact. And so who is going to be that point person for your organization? Is it the results going to go to pharmacy? Is it going to be called to the nurse? Is it going to call directly to the physician? How are you going to communicate that result, and who's going to take that result and do something with it? And then follow-up question to that would be what shifts are covered for follow-up. So not everybody has 24/7 micro, not everybody has 24/7 clinical pharmacy presence. And so thinking through how you might structure that is important. Thinking about overnight capabilities, if you do have 24/7 coverage, is someone going to follow up on that overnight? And does your micro process make sense where you might have results during that time period? So the next slide here is going to go over kind of our approach here in kind of like a visual format. The blue here that I'm going to talk about first is everything that's happening in the micro lab. So we get the blood culture that's positive, we get a gram stain with a gram negative. Here we would place that on the BCID2. Whenever we got a result were an E. coli or CLEB, that is then going to go on to the VITEK REVEAL. So those genetic and rapid AST results trigger in our EMR, and that EMR comes to, or that trigger, that notification comes to a pharmacist in basket. Micro also, at the point of blood culture and gram stain, will call that to the floor. So the bedside nurse, which is the same process we've had for ages, gets the initial gram stain from the blood culture, and then the nurse communicates that with the provider and addresses that at the bedside. And then when the additional results come back, that comes to the pharmacist in basket. And then the pharmacist is going to review the cultures, labs, the patient course, figure out what's going on, and give a clinical recommendation to the provider on the best treatment possible. The breakdown we have for the shifts in our institution is day shift or first shift is going to be an AMS offering this at all of our institutions. So we get that start in the morning, and we go through about 4 p.m. reviewing the cultures as they come back and reaching out and contacting providers. Our second shift depends a little bit on our institution. Here downtown, we have a pharmacy resident on call in the afternoon, and they are the ones who are getting that result. At other sites, we have afternoon clinical pharmacists who are getting that result and following up with the provider. And then most of our sites are also having the midnight pharmacist who's there follow up on the culture. Not everybody has aggressive clinical services overnight, and so that may not be something that everybody rolls out, but we do have that at some of our sites. We do have a little bit different approach from first shift versus second and third. Since the main medical team is not usually there for second and third shift, it's a covering provider. We focus more on escalations in the afternoon. So we focus more on those. They're not on active coverage. There's an ESBL and they're only on ceftriaxone, something like that. We found that we don't get a ton of yield on recommending de-escalations in the afternoon, since the covering physicians often don't want to make that kind of final treatment decision on top of the daytime primary team. So that's kind of how we focus that. And it also kind of reduces the workload for the pharmacist in the afternoon and midnight, who have a lot of other obligations, to only intervene on the cases where a patient needs that expanded coverage for safety. Next slide, please. So education, provider buy-in, of course, is super important. There's always going to be concerns over new testing. We got lots of questions when we rolled this out about, is this as good? And, is this, how does this compare with what things we have before? And so understanding some of the data behind the reveal and the comparisons that were done with classic AST may be helpful as you're communicating to providers. Making providers aware that you're going to have results much sooner. Providers may be used to knowing, well, I'm not going to know what this is for another day or so, and then that's not going to be the case anymore. So they're not really expecting to have that information. And then if you are running additional susceptibilities, knowing that there's going to be kind of sequential release of results. So yeah, I got the initial results that the drug I'm looking for isn't on there, but that will be coming kind of in the second wave of results. And so I think those are really important concepts to educate providers on. And then the follow-up process. If you don't already have some sort of rapid diagnostic service where you have a person following up and doing something with it, the providers may not be as comfortable with the recommendations if they're not used to them. So kind of letting them know what the follow-up process is and who's doing the follow-up and what kind of training they have may help inspire confidence for the provider with whoever is giving that recommendation. We can move to the next slide. So our approach, since we already had a rapid diagnostic service and we've been calling on blood cultures for quite a while, that piece of education wasn't as necessary, but more educating the providers that this was new, the data behind the reveal was solid, as an FDA approved susceptibility platform, and that the results would be coming back faster. So we presented to all kind of our major specialty groups throughout the hospital, critical care, GPU, surgery, and so far the rollout's been really smooth. And I think one of the benefits to this isn't like, to the provider, this isn't like a brand new test. This is just something coming back a little sooner. And this is an example of what it looks like in our EMR. And you can see the last column here where it says MIC Reveal is the only way that someone knows that this was on the Reveal platform. Otherwise, this looks identical to how we would see the result come back if it was on our VITEK 2 automated susceptibility or an e-test, which would just list e-test here in the method. Next slide. All right, so we kind of went over a lot of considerations for implementation and what you might want to think through as you're considering whether you want to implement the reveal or not. And so now I want to move into some patient cases. So we can move on to the next slide. These cases are real cases. I have made some modifications to them to make it a little easier for discussion, but they are all cases that we've seen with the reveal. So case one here, we've got LS, a 46-year-old female, presents to the ED. She's got severe flank pain, nausea, vomiting, malaise, past medical history. She's got a history of stage 1 breast cancer in remission, some periodic UTIs, and did have some antibiotics within the last 45 days for that. Kind of her vitals and labs here. She's got a little bit of a temp. She's got a white count, urine WBCs. Upon presentation at the ED, we determined that she had, 2 SIRS criteria, signs and symptoms of pyelonephritis. They ordered blood cultures, gave her a dose of cefepime. Blood cultures came back as E. coli on our rapid ID. You can pop to the next slide. So she had really rapid improvement with the 1 dose of cefepime and fluids. She's still in the ED at this point. Fever curves are improving. She's got symptom improvement as well. And so the team's kind of discussing, like, is an admission here necessary? Can we just observe her a little longer? And so this is a question I'm going to pose to you guys, is in your situation here, evaluating this patient, how might you approach? And then after that, we will move on to like how the reveal might have changed that approach. So option A would be start IV ceftriaxone. I mean, looking at our antibiogram, it performs pretty well, kind of medium spectrum. So it's not as broad as potentially cefepime, though still a pretty broad agent. We could continue the cefepime. So the dose is already given. We know it worked. She had improvement. They did have recent antibiotic use, so we're not really sure if if there is some acquired resistance because of that. We've got oral ciprofloxacin. It's a tried and true agent for pyelo. Our antibiogram doesn't look amazing for it at 75%, but she has improved really well. So that is a potential option, particularly since she's so subacute. And then we've got our oral amoxiclav, which I don't expect many people are going to choose that, given 45% empiric coverage. Even with no resistance mechanisms on the BCID, I still would be a little bit nervous about using that. But she has improved. It's a great oral option. We've seen a lot of data with using oral beta-lactams, particularly in like a urine source bacteremia. All right, so kind of looking at the results that are coming back in here. So kind of seeing a divide between IV ceftriaxone and IV cefepime. I did have a few people thinking about oral ciprofloxacin. Kind of looks like ceftriaxone is kind of leading a little bit here. My recommendation would have been in this case, probably would go with IV ceftriaxone, given we've looked at our E. coli when we don't have any resistance markers on the BCID, and ceftriaxone performs really, really well for them. So it's probably the route we would have gone. I do think the recent antibiotic use is a factor that could affect someone choosing cefepime. So I appreciate your answers there. So we'll kind of go into the next slide to talk about how the reveal had kind of changed this approach for us. All right, so here's the susceptibility profile that came back while the patient was still in the ED, which is pretty awesome. So the reveal showed pan susceptibility for the E. coli. The ED team actually, when the ED pharmacist saw this before the ID pharmacist, recommended a switch to amoxiclav to facilitate quicker discharge, given that it was susceptible. So this allowed an oral switch less than 24 hours from blood culture positivity. And I think this gives a lot of future potential. I'll be honest, I was a little shocked to see when I came across this case and saw that they'd already switched to oral amoxicillin clav. I was not expecting people to kind of already uptick it that easily. So I was really happy to see it, and the patient did really well and ended up not getting admitted. And so if we had started IV ceftriaxone, obviously they're not going to start someone on OPAT ceftriaxone from the ED. So that probably would have resulted in admission if we had done the IV ceftriaxone. All right, we can move on to case 2. Okay.
Really,
case 2.
sorry, Dr. Avery, as we get into these cases, if everyone you can use that chat function if you'd like to put some rationale behind your answer as well. For any brave souls out there, we appreciate the discussion. So thank you.
Yeah, appreciate that. Case 2, TS is a 62-year-old male who has developed high fever during an inpatient stay following multiple abdominal surgeries for bowel obstruction. Blood cultures were obtained. A code sepsis was called due to his deteriorating status. His vitals don't look great. He's got an elevated white count, high lactate. They started vasopressors in him. After only a short time incubating, the blood cultures came back positive. They were typed as a gram negative, and we put them on the BCID2. Move on to the next slide. The BCI2 showed cleb-pneumo, no resistance genes detected, and which would identify CDXM and carbapentamases. So which approach might you go for the next management steps? So IV ceftriaxone is what we recommend for cleb-pneumo that has no resistance mechanisms on our rapid blood culture ID guidelines that we have. Because again, we kind of look at those isolates and say, okay, if we don't have any of these resistance mechanisms, what's that look like? And it's a really high coverage. We could do IV piptazo. We know that this is an intra-abdominal situation. Some people might want a little additional coverage. Also, this cleb was likely acquired in the hospital given his prolonged stay. So the potential for resistance that maybe not caught by a genetic marker is definitely there. And then we have the additional option of IV Miro, which is kind of the same concepts as piptazo, right? Is that we don't have a CDXM, so we don't expect an ESBL. However, there could be other types of resistance that aren't caught there. Knowing this is more of a hospital-acquired pathogen, that IV Miro might be indicated here as well. So those are kind of 3 potential approaches. And this one, we actually did use one of these. So I'm kind of seeing kind of dueling IV ceftriaxone and piptazo with IV ceftriaxone going a little bit heavier here. In this case, when I looked at the result, we had not had the reveal yet. I was kind of on the fence about the IV ceftriaxone given how quickly he decompensated. So I was a little bit nervous there. We hadn't gotten much antibiotics in yet. Saw that it potentially was acquired in the hospital. So the team had already ordered piptazo. I didn't end up recommending a change to ceftriaxone given that, and went with the piptazo for the team, kind of expecting that we wouldn't be super excited about dropping down to a narrow spectrum agent as vasopressors are being started and that sort of thing. So appreciate everyone's thoughts there, but you can see that you guys have the same kind of back and forth that I did on the case. So we can pop on to the next slide. This is going to be the reveal results that we had for this case. So when the reveal came back, we actually had a resistant piptazo on here. If you kind of look at the rest of the susceptibilities, most things are susceptible. We do lost AMP sulbactam. Not that surprising if there's some sort of beta-lactamase, because sulbactam is not maybe our strongest beta-lactamase inhibitor out there. And so we did a confirmatory e-test as well on this case because it seemed kind of odd to us to have this had this piptazo resistance where we saw everything else is susceptible. And the confirmatory e-test did come back as a resistant piptazo. So in discussions with our microbiologists, there's a couple different options about what could be going on with this isolate. Potentially a TEM ESBL, which would be a little bit different in terms of its potency versus like a CDXM. So there's lots of potential things that could be going on here. I think the most important piece of that, though, is that our biofire that we have, or our genetic markers, missed this. There wasn't a marker here to detect to note that there might be some piptazo resistance. And so actually the drug that was chosen, which was chosen out of abundance of caution, trying to use a broader spectrum agent, actually kind of backfired a little bit, and that was actually resistant. Not anyway, and we could have known that up front. I think the thought process behind piptazo was perfectly fine. The patient did improve after a pretty quick switch following the reveal results, which is nice because we got these results. It would have been another day, maybe longer, to have the results without the reveal, and that may have had a different outcome for the patient potentially. So while genetic markers are really useful, and have actually helped us probably save a lot of lives, they're still not perfect, because I guess no test we're ever going to have is perfect, and there's area for improvement. We can pop to the last slide here. So in conclusion, VITEK reveals a new rapid AST technology that's got the potential to help patients get on the best therapy possible sooner, whether that's escalation or de-escalation. It's not a one-size-fits-all test, which is great because stewardship programs are also not one-size-fits-all. And so there's lots of different ways to implement this into your workflow, to use the VITEK reveal aggressively in a lot of patients, or saving it for patients that you are most concerned about, organisms you're most concerned about. So there's a way to implement that may work for your institution. And then anecdotally, we don't have any data yet, although we do plan to look at data with our reveal in several different scenarios. But anecdotally, between myself and my infectious disease residents, who also help follow up on these on a regular basis, we've had a lot of situations where we've been able to do an earlier de-escalation and a few other escalations that might not have been caught as early. So we're only a few months into this process, so I'm sure there'll be more lessons learned for us as we go along. But so far, we feel like there's a pretty significant clinical impact from what we've seen so far. And I appreciate everybody calling in today, whether it's morning or afternoon for you. And I think we'll move on to questions now.
All right, great job, Dr. Everson, and thank you for all those great insights. And I think what you highlighted, right, is that when Fast AST is rolled out in a thoughtful, coordinated way, like you did at Henry Ford, it can meaningfully impact both management decisions and outcomes. So thank you. So with that, we can kick off the Q&A portion of the program. All right, so a key part of success in deploying new diagnostics is whether or not the clinician receiving those results knows what to do with them. You touched upon education a little bit during your presentation. It sounded like your institution has had quite a bit of experience with rapid diagnostics for quite a while. So the question here is, what advice do you have for those who have never rolled out any rapid diagnostic test before? So essentially, they're transitioning from a traditional microbiology to now having Fast AST for their positive blood cultures.
Yeah, I think that's an excellent question. When rolling out a new rapid diagnostic test, I think the cornerstone is the follow-up on it. And I think there's so much data telling us that just running the test and hoping that it makes a difference is not that beneficial. Whether there's really strong education on the follow-up, some sort of alert to the provider, or what I personally think is best is going to be the having a point person following up on that, whether that's a physician, whether that's a pharmacist. The cases can occasionally be difficult, and so you may question, again, any pharmacist do this, any provider. I do think someone having a decent amount of comfortability with infectious diseases and looking at patients, because even just having a rapid result, I know there is E. coli in the blood, but reviewing the patient, I'm seeing a giant abscess in their liver, and they've had multiple surgeries, and I may not be confident that that is the only organism, knowing a lot of these are polymicrobial, that may affect my recommendation. And so I think that making sure your point person has some training and some comfortability there will really help you kind of take it to the next step. And I think then also making sure that the providers have confidence in those recommendations, whether that's a physician or a pharmacist making those recs, knowing where that recommendation is coming from and why they're making it, I think will really help those recommendations go through, as opposed to just like cold on that education piece to help increase confidence in those recommendations. I think is really important.
No, that's a great perspective, and definitely agree as an infectious disease as pharmacist also. Actually, the next one is also related to ID pharmacy. So what do you view as the overarching role that the infectious diseases pharmacist plays in bringing on a diagnostic tool such as the VITEK REVEAL that can have an impact on antimicrobial stewardship?
So for better or worse, pharmacists I think are very process oriented folks. We like bullet lists. We like knowing how things work and how things integrate. And so I think that an ID pharmacist is really essential to work with that microlab to figure out kind of that diagram that I showed you, what that workflow looks like for you, and who's responsible, how that's all going to flow. Having a really strong knowledge of how things work in the microlab is important. We're super lucky here that we have two amazing PhD clinical microbiologists, and we work really closely with them. But this can still be done with all kinds of microbiology labs. But having that close relationship between pharmacist and micro, and I think it tends to be a little better when it's an ID pharmacist who has had training in the micro lab. Like our program does do like a month-long ID or micro rotation. So our residents and our pharmacists are very comfortable with what the process is in the micro lab and what time points we'd expect things to come. And so if you didn't have an ID pharmacist doing this and had another pharmacist following up who had some ID training or was kind of focusing that, integrating with the microlab, understanding the time points when things should come back so you can kind of learn to expect when cultures are there, that process piece is really important. And that's personally why I think pharmacists are really well suited for this follow-up, is understanding all of those nuts and bolts of the pieces, giving the recommendation to the provider. And the provider is the one at the bedside who's seeing how the patient's doing, and they can kind of integrate that recommendation based on what they're seeing at the bedside as well. So I see it as a kind of a really nice collaborative approach when it comes to it. Because like when you think about pharmacists, we're not typically super involved in diagnosis. In this case, we're getting an ID, we're getting information, and then we're using that to come up with a treatment recommendation, which is where our expertise is. So I think it's a nice way to kind of marry skill sets.
Yeah, absolutely right. I think, and I think you hit it well, that we're not diagnosticians. So once we can if we can have that diagnosis faster, that helps us do our job better. So, and also I really love that algorithm that you shared. I think during the process of who's being called when and how people are acting on it, that's, I think, really important for success as well. All right. So our next question here is that if faster susceptibility information could change just one thing for your patients over the next year, what would you want that to be?
One thing is kind of tough because I feel like at the end of the day, our two biggest focuses when we have the reveal is going to be focusing on getting people on oral therapy and out of the hospital sooner, which improves all kinds of things. Not only does it improve the patient experience and generally outcomes, because we know the longer they're in the hospital, the more likely something bad is to happen to them, no matter what hospital they're in. So as much as it may seem like it's a metric for hospital administration to get people out of the hospital sooner, I think it's a clinical metric for me to make sure that they're treated and they're not going out on OPAT, they're not getting PICC lines. And so having this opportunity to kind of tank them up for that much sooner, I think is really beneficial. But we do have a lot of resistance at Henry Ford. We're not, certainly it's not an antimicrobial apocalypse here, but we do see resistance very frequently. And in having the ability, particularly on some of our more gnarly organisms like Pseudomonas, getting that susceptibility result sooner, I think is going to save some lives in the long term. So it's kind of hard because I think there's a clinical benefit both ways. So I guess the thing I'm the most excited about would be an increase in clinical benefit for our patients, whether it's one or the other. So I'm going to cop out and not choose between those two.
So our next question actually kind of feeds into that resistance that you just mentioned. So it's, what is the value of the VITEK REVEAL since you recognize resistance markers from the BCID2, so essentially having a molecular test? and assessing your institution's antibiogram and your institution's sepsis protocol. So I think the question is kind of saying, what does VITEK REVEAL add to that equation? If you're already getting resistance markers from, your molecular test, you already have an antibiogram, what's REVEAL's role?
Yeah, that's a really great question because I think there are situations where there might be limited returns from reveal depending on what your isolates look like. If you're not seeing any significant resistance, you have a pretty friendly antibiogram. The genetic markers may be catching the vast majority of the stuff you're seeing. I think what you identified in the last case, there are some situations where maybe that's not, but they're going to be pretty maybe few and far in between for you. To me, that's where the added element of the quicker you can get people de-escalated. I mean, we know that I can't remember the percentage off the top of my head, but every additional day of pseudomonal coverage increases the chances of resistance significantly. We know that every day of extra broad coverage increases ESBL selection, C. diff rates. And so a day of therapy of narrower therapy is actually pretty significant. I know in the grand scheme of things, it doesn't always feel that way, but the data does suggest that is significant. So even if you're like, hey, I don't have a ton of resistance, even when I look at the ones that are resistant, the BCID has identified all of them, I think then the pivot is there any benefit to you getting that susceptibility earlier and getting people on a narrower therapy and more of a final therapy earlier so you can start queuing up a trip home if they're ready to go. So I think that's kind of the flip of it. But I think that really depends on what your workflow is like and what you're kind of seeing in terms of isolates, in terms of how much benefit you're going to get from a resistance standpoint.
Yeah, no, and I think for kind of highlighting I think as pharmacists, right, we often hear that in clinical practice, just one more day, right? Like what's the harm of one more day? But like you said, we do have that data showing that each additional day of an anti-pseudomonal agent is absolutely significant. And kind of speaking to that, and I think you hit on it during your presentation as well, when we think about Pseudomonas, right, maybe not lending itself well to these molecular tests, that might be one where you have that difficult to treat resistance profile, that it might have potentially play a big role there, since the panel does have things like Ceftol, Tazol on there, and Ceftaz-Api. So thank you. All right, so our next question is, in general, do you see that the medical team will ignore the fast AST results and wait for the full panel? So I think what they mean by that is maybe your standard of care, if you opted to run that behind fast AST.
Yeah, so we don't really have experience with that question yet because we're not running the additional susceptibilities on these two organisms. So E. coli and Cleb, we're getting basically a full panel back from the reveal. There's no real additional susceptibilities that we need, other than there's resistance and we're adding on something later. But even then, we've got kind of our big resistance agents on this already. So we really, in these cases, haven't added on any susceptibilities. I expect there probably will be. That is a concern when we kind of move to having that maybe more of a bimodal report structure for things like Acinetobacter, where we get some of those initial results and then we're going to wait for that next step. So there is potential for multiple changes in antibiotics, and then you are exposing people to multiple classes. So there's maybe some pros and cons to that approach. So I expect we'll probably see a little bit of that, and I think that's where your education needs to come in when you're rolling this out. To show like it is important to act on information when you have it, due to what we just kind of talked about, is that like a day less of therapy can be really impactful. A day shorter of broad spectrum can be really impactful, and it's going to allow you to do better for your patient sooner. And so I think that may be kind of a beneficial angle as you're doing your education and kind of getting that initial buy-in from providers. I think just plugging this in and just making it happen without any sort of like engagement with your providers, that this is kind of a little bit of a new approach to treating infections, you might run into more problems in that area if you don't do that initial buy-in.
Absolutely. And I think, yeah, you've done it right. I mean, it kind of goes back to that initial education, make sure people know how to act on those results. So our next question kind of it covers the institutions that don't have a 24/7 lab. So it asks which shift you are running Reveal, so first, second, or other shifts, and if the If the result is available in the second or third shift, are there lab personnel to release the results into the LIS system for pharmacist review? And I think the second part of the question here is that, we do acknowledge that there are a lot of non 24/7 labs. And you mentioned that your lab is, but it's in the US, it's in Europe, other parts of the world as well. I think it's kind of getting at the question of, if you were the lead stewardship pharmacist at one of these sites that doesn't have a 24/7 lab, how would you maximize the value of fast AST?
Yeah, it's a great question. I've never worked in a place without a 24/7 lab, so I realize I'm incredibly privileged in that way. But as I kind of think through the process, we are running the reveal kind of around the clock. But if your micro staff are coming in the morning, I would imagine they start relatively early, and if they're not doing 24/7 coverage, you're taking those blood cultures, you're working them up, you're putting them on the reveal. You have like roughly 6 hours to get results back. So hypothetically, you've got results the same day that you're running that reveal in the morning. And so I think working with your micro lab about what their workflow is going to be. Can they prioritize the reveal? I mean, generally, our microlabs are always prioritizing blood cultures. Like, we've got chimes going off, letting people know that the cultures are happening. They're usually a pretty big focus already. But in terms of, I think that's where working with your micro lab is essential, is to, what is your process for that? When are we expected to put those on the reveal? I know the time point is going to be maybe this time frame. That gives you the opportunity as a clinician to either have someone kind of available during that time, or know to be looking for those cultures as they come back. You can have an alert system through EMR. There's a lot of different ways to be notified from your lab, and you can kind of figure that out locally. But I think there still is a ton of opportunity in potentially day shift to get all of that done. And then the next day you're going to have it all reported. You're still going to have an improvement in time, because you're still knocking out that whole day of subbing out an isolate and letting it grow, because that's even longer when you don't have a 24-hour micro lab potentially. So that may even go longer than 24 hours depending on how long it's been there for. So I think you could make an argument that the rapid AST is even more relevant in a situation where you don't have 24-hour micro, because you're already having some delays in reporting, and so this is shortening that delay even more. I think the thought process also applies to like send out, or not send out, but 4 of our hospitals don't have on-site micro, so those results are all coming to us. So my thought for them is the reveal is even more important there, because now we want to get them susceptibilities and information as soon as possible, since there's a delay in the courier process and working up and that sort of thing. So I see more of an impact there. And if there's no one running it overnight, you don't have to worry about needing the person to follow up on it overnight as it comes through. And again, overnight follow-up, I personally think in most cases a de-escalation is not worth an overnight clinician's time to look into it, unless the culture at your institution is, the covering person overnight is really comfortable making big changes in terms of de-escalations to therapy. I just find that that's not a practice that anywhere I've worked, that the covering overnight clinician has been really gung-ho to de-escalate the antibiotics on top of the daytime team. Whereas they're obviously going to be very interested in an escalation. I do know some places that actually have a kind of a per protocol for escalations at night, where the pharmacist can enter in an escalation per a protocol that is comes back as our case would be a CDXM positive. They can't get a hold of the provider in the middle of the night, and so they're able to just put a dose of ertapenem in to make sure the patient is safe and covered until the morning. And so a process like that could also be in place if you, depending on how your workflow is overnight, where they could look at, as long as it's, if there's something resistant to what they're on with the reveal results, then you can intervene. So I think there's a lot of different ways you can kind of integrate it, which is one of the reasons I like the reveal, is that I think it's got a lot of flexibility to kind of be implemented. And I think it'll help in these various scenarios, because you're still having that, cutting out that entire day of subbing, regardless of what your micro schedule is like.
Yeah, that's a really great point, and absolutely my experience as well, right? I mean, it's tough to wake somebody up necessarily to de-escalate, right? But the escalation is going to happen 24/7. So thank you. All right, so this might be our last question here. So when providing recommendations for changes based on rapid AST results, do you find yourself also using this opportunity to recommend appropriate durations?
That's a great question. In general, I would say we're probably not making a lot of duration recommendations because we're usually talking the first day or two of therapy. It particularly in patients in the ICU where maybe the full source of the infection is still kind of being actively worked up. But in the case of something where it's kind of like a slam dunk, like in like the case one we had here, where we had a classic pyelo with a bacteremia, the patient responded really quickly. That would be a case I'd be very comfortable making a 7-day duration right there. Our institution's pretty good across the board with 7-day durations for gram-negative bacteremia. We've had a lot of uptick from our providers on that. We've been kind of really blessed with that situation, but it's definitely not the case everywhere. So I think in those infections that are those like infections that we've studied with all the 7-day bacteremia trials when we think about a simple intra-abdominal source, which determining whether it's simple or not can also be difficult that early, a urine source, a skin source. Those things I think I would be comfortable giving a duration recommendation up front, particularly if I've already seen a little bit of improvement in the patient since they've been there. That first 48, 72-hour response is often very predictive of only needing a short course.
No, that's really helpful and great to hear that yeah, you're adopting more the shorter is better, right? Those 7-day durations. All right, so with that, that's all the time we have for today. Dr. Everson, thank you so much for sharing your experience and for the thoughtful discussion. We really greatly appreciate it. And just a reminder, all registered attendees will have access to the recording, so feel free to revisit today's session for practical considerations around implementing FAST-AST. And then thank you to everyone who joined us live from around the world today. We appreciate you taking the time. So have a great rest of your day. Bye, everyone.
Thank you.